So we'll talk about Aprv. As we talked before, the vent lectures are divided into 3 modes of ventilations that are old or obsolete, 3 modes that are current. We talked about CMV, we talked about AC, we talked about SIMV. 3 modes of ventilation that are current: pressure support, volume control ventilation, and pressure control ventilation. We talked about this, and this. We're gonna have to like really delay this a little bit till the end of the rotation or something. And there's advanced modes of ventilation. One of them is Aprv bi-level / bi-level, V-sync, and AVAPs. And we talked a little bit about AVAPs before. So we have these 2 to talk about. I'm going to start with this, and then we'll see if we have time for the V-sync. All right, so Aprv, the need for Aprv started when we had patients on pressure control with inverse ratio. Remember we said when you inverse the ratio on pressure control, you have to paralyze the patient. So we had people with pressure control and inverse ratio, which basically required paralysis. But after a day or 2, we was like, okay, what are we gonna do? We have to take off the paralysis, otherwise the patient's gonna be very weak, requiring a trach. So that's why people looked for a mode of ventilation that would help us stop the paralytic and still maintain the long eye time without the need for paralysis. This mode has been invented for 25 years. I was playing with this when I was a fellow, so it's nothing new here. Tell that to your to people that you know. So this is pressure controlled ventilation with inverse ratio. That requires paralysis. That's how it looks like in the pressure waveform. This is Aprv. Aprv stands for airway pressure release ventilation, which it already is giving you the name of, or the mechanism of the mode already. Airway pressure release ventilation, which means it's an airway pressure that is released every once in a while. So you go like this. Nothing is moving, right? And then it stays like this. So how come this guy here doesn't require paralysis and this guy requires paralysis? Because here you're breathing on, you're allowed to breathe. The machine, if you want to breathe, the machine can open the valve for you and you can breathe normally. So you can go like this. Really, you don't care. It's really, the patient, it's actually less sedation required than volume control and pressure control, because the patient can breathe whenever they want. So they feel as if they're just a high peep, and they're breathing over the high peep. And every once in a while, something weird happens like this. Rare, every like 6 seconds, 8 seconds, something like this happens, which is, what is this? Okay, we'll breathe again, or so for the patient, it's really very comfortable to breathe on your own whenever you want, whatever amount you want, and all of these things. Here, you can't breathe on your own. If you want to breathe on top of the pressure control like this, the machine doesn't assist you to breathe, nor even open a valve for you to breathe. So you are like, you're suffocated. And when the patient feels that, they get very, very anxious. And these patients are tachypnic. So they are going to breathe over 2 seconds. You know, they're not going to let you hold them up for 2 seconds. So you have to paralyze them for pressure control. And you shouldn't paralyze them for Aprv, because you're benefiting from all of these small breaths. So that's the pressure waveform, obviously, right? Let's talk about the set parameters. The set parameters are from here to here, that's called low pressure, and that ranges between 0 to 5. And then from here to here, it's called the high pressure, and that ranges between 25 to 35. And when I say ranges, that's startup settings. We can titrate lower than that or longer than that or whatever we want. But to start, usually start this like this. And then the high time, from here to here, it ranges between 4 to 8 seconds. And then from here to here, it's called the low time. And that ranges between 0.3 to 0.7 seconds. And then each one of those small ones here can be supported with pressure support breath. That's called pressure support 0 to 10. And then the FiO2. So how many set parameters we have? 6. High pressure, low pressure, high time, low time, pressure support, and FiO2. Let's talk about the flow waveform. So if you decided to forget everything that you learned in this lecture and erase it from your head, you can't forget this one. This is how you're gonna kill patients with the flow, if you don't pay attention to the flow waveform. So the flow waveform looks like this. Like basically, as you looked at my chest, right? There was no flow. There's no flow. Maybe a little bit like this. Tiny flow here. Huh? Okay? And then when it comes to the release breath here, we call that the release breath, it goes like this. So the majority of the movement, it happens in the negative direction, and it happens in this situation here, as you're falling from the Niagara Fall. Boom, the pressure just falls very low, from very high to very low, and you get a huge breath here, relatively huge breath, which is called the release breath. The terms are very important, especially in this. The terms, you can kill patients if you change the terms. This is not called the machine breath, it's called the release breath, and this is called the spontaneous breath. Okay, what do we call this in other modes of ventilation? If you have a mode of ventilation that has exhalation, it goes like this, and it doesn't finish. We call that the auto peep, right? If we call that the auto peep here, the respiratory therapist is going to have a heart attack, because he's going to find that the auto peep is 55, and he's going to seize in front of everybody, right? So we don't call it the auto peep. So I'm going to start telling you throughout this the claims to fame in the Aprv. The first claim to fame that we talked about, that it doesn't require paralysis, right? Even though it gives a long eye time. The second claim to fame is that it debunked the classic teaching about auto peep. We were thinking, or we were taught, everybody knows that auto peep is dangerous. And we agree, everybody agrees, I still agree that the auto peep is dangerous. But here, it just tells you something, that it's dangerous if you don't regulate it. If you regulate it, you can use it to your advantage. That's the point. So it's not dangerous all the time. So this mode is using auto peep to improve the patient's recruitment. But regulating it, because if you don't regulate it and let it be, like it might actually pop the patient's lung or cause severe reduction in the venous return. So how they regulate it? They measure a ratio. We measure the ratio every 2 hours. We measure this ratio. We put the cursor on this curve here at the lowest part of the curve. You gotta do this every time we have a patient with true Aprv, classic Aprv. When we do here, that's called the peak expiratory flow, and it's in the negative, obviously. And then you put the cursor here, and that's called the end expiratory flow. And if you divided EEF by PEF, the ratio should be 25 to 75%, which is not a bad ratio. It's a very big range that you can play with, but if you're outside of that, you're gonna cause a problem, right? So let's say the PEF to PEF, the ratio is 85%. What does that mean? That means that we finish the curve here, right? Because this is 75. This is like 50% of that. This is probably 85% of that, or something. Because they're close to each other. Right? This and this, right? So that means the patient is gonna. So that means the patient is gonna have extra auto peep, and the patient might pop his lung, right? So what do we do for that?
Extend the low time.
So extend the low time. You have to increase the low time. So we'll make the low time a little bit longer, and then that will improve the patient's condition. How about if we have somebody with a ratio of 10%? What does that mean?
Yeah.
Obviously the opposite. It means that we let this go all the way to here, so this became 10% of that, and that means this patient is going to de-recruit his lungs and has hypoxia, and de-recruitment will cause, you know, some of the alveoli is gonna completely close because of what? If you reach actually all the way to zero on the flow, that means that your lung doesn't want any more flow. That means you actually like exhaled fully. That means that the lung is now seeing the low pressure, which is what? Very low, 0 to 5. So if the lung sees 0 to 5, so you're ARDS patient, and I give you a low pressure of 5 or people 5, that means that you're gonna have de-recruitment, and then the next breath comes in and open the whole lung again and cause severe inflammation. So that's worse than hypoxia. Actually, it scares me more than hypoxia. So anyway, so this means that you de-recruit the patient. You need to reduce the low time. So let me ask you this. So let's say we do this every 2 hours, and we ask the respiratory therapist to, I mean, we don't do the respiratory therapist every 2 hours. We ask the residents to actually, when they go around, if you see a patient with classic Aprv, this is the one that we order every day, is not classic Aprv, it's bi-level, right? So classic Aprv, you have to do that ratio. And the nurses, if they can, do that ratio. You're not changing the vent, you're just freezing and measuring. You're not changing the settings when you do it. Because it's important. So let's say you did that ratio in the morning rounds, and you found that the ratio is 50%. And then you did the ratio in the afternoon or the night rounds, and we found that the ratio is 60%. With the same settings. What does that mean? Does it mean that the patient is improving or the patient is worsening? So, if you think about it, it looks like this. This is 50% of that, right? Right? This is 50% of that. And then you come in at night and it's 60%. So that means this is it here now. That means your curve went like this.
So worsening.
That's improving. Yeah, we'll talk. So this one here, if you're if you're ARDS patient, your curve is gonna look like this. The more ARDS, the more exhalation is so fast, it's so stiff, and the lung finishes. If you're COPD patient, your curve goes like this. So the opposite of each other, and the normal is in between. The more you move towards COPD, the more that means that your compliance is improving. Right? So that patient that you put them on Aprv, the compliance now is improving. Also, if you think about it, this here is what? This is an additional area under the curve. So this is an additional tidal volume. So the tidal volume that you were giving the patient with certain settings is now increased without changing the settings. That means the patient recruited new alveoli, and so that's what it indicates that the patient is improving. But that's only in 99% of the time. Okay, there's 1% of the time the patient could be worsening, not improving. Could be worsening, which is what? Remember this curve? Imagine if the curve is like this. Instead of the EEF increasing, the PEF decreased. This went to here. And this becomes the curve. So this is actually an area that is lost. This area here under the curve is lost. That means you lost tidal volume. That means you're not getting your tidal volume. So that's obviously happening in what? Bronchospasm. Because bronchospasm or COPD, you can't exhale. The exhalation is not fast. So you're muffled a little bit in your peak expiratory flow, and that's why they approach each other, and it looks like this, and you lose tidal volume that way. But this is only 1%. It never happened. It really, really very rarely happens. Right? And the reason is, it's another claim to fame to this mode. Which is what? Which is that it does prevent bronchospasm. It doesn't allow the bronchospasm to happen. If you talk to any pulmonologist, he'll tell you that one of the ways we treat bronchospasm in status asthmaticus, if everything else fails, is PEEP. PEEP is a bronchodilator because it just stents the smaller airway open, even if the small airway wants to collapse, because acetylcholine and troponin and everything is working inside the cell to make it spasm. This thing is stenting it open like this. 8 of PEEP, right? 10 of PEEP. This is like 35 of PEEP. This is a huge amount of PEEP. No bronchus will dare, can't. Even if the nerves are, everything is telling the bronchial cells constrict. I can't constrict. There's 35 of PEEP there. I can't, right? So that's why you never see it, and that's another claim to fame for this mode, But you can see it if you have what, like kinking of the big upper airway stuff, kinking of the airway, kinking of the endotracheal tube, mucus plugs, something like that can happen like this, right? So the typical question is that, can we use Aprv in COPD patients? Because by definition, the low time is very short, and it's not enough for COPD patients to exhale fully, right? So yes, you can, and that's another, or you should actually, that's another claim to fame for this mode. The age-long question, when you get somebody with COPD, when they come here, rarely we intubate somebody for just COPD. We usually have either COPD and pneumonia, COPD and ARDS, something like that. So if you have somebody with COPD and ARDS, what the big question is what? How, the big question is, which one of these parameters or of these diseases is affecting the patient the most? Like, is it the COPD that's playing the bigger role, the obstructive nature, or the restrictive nature, which is the restrictive disease from ARDS? Which one is playing the bigger role? And this mode is going to tell you which one is playing the bigger role. If you put the patient on a regular setting, 0 to 7, 0.3 to 0.7 low time, and you see that the ratio is 80%, that means that you need to prolong the time. So you prolong the time, make it 0.7, 0.8, 0.9, max is 0.9 for this. Once you reach 0.9 and the ratio is still high, I mean high, like, okay, 70 or 72, like, I don't want to play, close to the 75, right? So when you reach that level, you increase the time all the way to 0.9, and you still have 70 in the 70s time. That means what? That means that the COPD is playing the most role, because he's very compliant. I'm just give 0.9 and he's still not able to exhale fully with this. It's taking time.
They need a signature.
Let's say whoever sent it out.
So,
Let's do some honor.
right, 0.9. So that's what we. That's as opposed to the opposite. If you put the patient on this mode of ventilation and the patient just takes it, and with good ratio, that means the ARDS nature or the restrictive nature is more prevalent in this patient. All right, and we will stop here.